Thank you so much, Dr. Greenberg, for that nice introduction. Before I start, I'd like to thank the Transverse Myelitis Association. It's really an honor to be invited for this talk, and also for their generous support of my education through the Lubin Scholarship. Oh, good. So today, my talk is on acute disseminated encephalomyelitis, or ADEM for short. We'll review sort of where we've been in the past, what our current understanding of the disease is, and what the future might hold. I have no disclosures besides being funded by the TMA, and I'm the procrastinator of the group, so my slides will look a little different from your handouts. So what is ADEM, besides being a mouthful? So acute means abrupt, disseminated means widespread, encephalo refers to brain, mild to spinal cord, and itis means inflammation. So you have a condition that leads to abrupt, widespread inflammation in the brain and spinal cord. That sounds frightening. What does it look like? Well, depending on where in the brain or the nervous system that the ADEM happens in, you can get all sorts of symptoms. It can span everything from headache, irritability, to even confusion and lethargy. Some people have seizures. Some come in looking like they're in a coma. So it can be very, very disturbing when it initially starts. Why does it happen? Despite our best efforts, we still don't know, as it goes in many of these rare neuroimmune diseases. We think that there's a role for an infection because in about 50 to 75% of the time, there is a preceding infection. It may have to do with something about the particular person. You know, are they vulnerable for a specific reason at a specific point in time? Usually days to weeks after that initial infection is when the symptoms will happen, and that's a result of the inflammation that goes on in the nervous system. So who gets this disease? When I started learning about ADEM, it was always described as a childhood disease, and coming here to this symposium and talking to some of you, we definitely know that that's not true, and sometimes the most severe cases can happen during adulthood. But most commonly, we see it in children between the ages of 5 and 8. The gender ratio is 50-50 usually, but there may be a slight male predominance, which is unlike a lot of other autoimmune diseases. The incidence is low. There also may be some relationship to how far you live from the equator and how likely you're to get this disease, and we might speculate that might have to do with vitamin D levels. And it happens in the seasons that we get sick most, which usually is the winter and the spring. How do we diagnose it? We call it a clinical diagnosis, meaning we don't have a perfect test. So we try to do a very detailed history taking, and this is when you have the medical student ask about every single pet you have and every place you've been in the last 5 years. Sometimes we'll cover the story that there was a preceding infection. We do a very careful neurological exam, and oftentimes we find multiple different types of neurological symptoms, and this concept of encephalopathy, which really just means some alteration in consciousness or awareness. We'll do things like blood and spinal fluid tests, which may show inflammation. And the whole point of this exercise is really to not only confirm ADEM, but also to eliminate alternative causes that we would treat differently. You wouldn't want to miss a stroke, serious infection, cancer, or a genetic metabolic disease. Here are just some samples of MRIs of, I think, children with ADEM, and you can see that it's quite variable. In some cases, is this cursor right? You may have these smaller lesions. The white areas are the abnormal parts. Sometimes you have tumefactive or tumor-like lesions, as you see here. These are affecting the white matter or where the wires run in the brain, but it also can affect the deeper gray matter in parts of the brain called the thalamus or the basal ganglia. And in some hyperacute and aggressive forms of ADEM, you may even get bleeding into the brain. So how do we treat ADEM? Unfortunately, we kind of use the same things that we use for all of these diseases, and we think it works by suppressing the immune system. So IV steroids is sort of our first go-to, and that can be given for 5 days in the hospital. Then typically we'll do an oral taper over 4 to 6 weeks, kind of just to decrease the chance of some rebound inflammation coming back. And then if it's a particularly severe case of ADEM, or the child or adult doesn't respond favorably to the IV steroids, we'll do something like IVIG, which is pooled human antibodies, or plasma exchange, which is a kind of a blood filtration technique to kind of take the bad actors of the immune system out of the blood. All of this is based on just observational data. A panel of experts sat down and said this is probably the best way to proceed, but it's never, nobody's ever done a clinical trial to actually prove this. So what is the prognosis of ADEM? I know this is important to a lot of you in the room when you're thinking about your loved ones. For the most part, we think of it as a pretty favorable outcome, and that's for the average person, definitely not the exceptions. Most people do well with the steroids, and over the course of several months, they may have a nearly complete recovery. Typically, it's monophasic, meaning it happens once and it doesn't happen again. But definitely some individuals can have persistent cognitive problems, sometimes very serious, and some individuals go on to have relapses of this disease. So here's just a little schematic of how we classify ADEM, and this is all based on a lot of seminal work that Dr. Banwell and others have done. So if we have the first time onset of an episode that fits the criteria for ADEM, we call that monophasic ADEM. We kind of give you a grace period of 3 months for the MRI to kind of change a little bit and for symptoms to fluctuate, but really after that 3-month mark, there shouldn't be any new symptoms, any new MRI changes. If you were to have another episode of ADEM, this is kind of when we get into more controversial territory. This is currently called multiphasic ADEM. If there's a presence of encephalopathy, if it's an episode that is just transverse myelitis or optic neuritis without really change in the child or adult's behavior or awareness, then it kind of gets named one of these things based on what the second event looks like. And then pretty much as a community, we agree if you have a third episode of ADEM, that's just not ADEM. So here is sort of what we do at our clinic. Initially, the MRI can look quite ugly and scary like this. But as it turns out, when we scan the child or adult 3 to 4 months after, we see often resolution of all those lesions in the brain. I think getting this study serves 2 purposes. One is to first see if it kind of follows the pattern of ADEM, which is for many of those lesions to go away. And the next is it serves as a baseline for future comparison. So if we were to get another MRI that had new lesions, we would kind of have to rethink the diagnosis of ADEM a little bit. So let's delve a little bit into the past to see if there's any lessons that we can learn. Just to go through a little bit of the initial history of ADEM, it was first described as early as the 18th century. In that time, it could have been called something such as post-infectious encephalitis. So even back then, people found a relationship or noticed a relationship between infections, but it didn't seem to be one infection. Pretty much anything you can think of, viral or bacterial, has been implicated in the pathogenesis of ADEM. What else can we learn? The other name for ADEM in the past was post-vaccinal encephalomyelitis. And we get this question a lot: are vaccines okay for my child? We have one event that the immune system kind of misfired. Is it okay to give them something that will probably rev up their immune system? And I think it's informative and instructive to look at one of the most implicated vaccines, which was the original rabies vaccine, to kind of understand that why this may have caused the outcome. So kind of vaccine development 101, we have the rabies virus. We give it to an unsuspecting animal, unfortunately, who doesn't survive the infection. We take the virus, which in the case of rabies is mostly in neural tissue. We treat it with some chemicals to kind of decrease the potency and make the virus weaker. We also add some things that kind of tell the immune system to, hey, pay attention, and we make it in the form of vaccine and give it to the human. Most of the time, we get the intended outcome, which is for the person who was exposed to rabies to make a response to the rabies virus and survive the infection. Unfortunately, I think in the case of the original rabies vaccine, some people developed an immune response against the neural tissue, and they got a syndrome that looked a lot like ADEM. So I think my purpose in telling you that is that modern vaccines are much safer. We don't use neural tissue. We grow them in other types of tissue that wouldn't cause the immune system to get confused. And I think it's important that as a society we continue the immunization schedule just for everybody's benefit. And then last, I want to take a look briefly at animal models of ADEM, which interestingly happen to also be the animal model that has been used in MS for a number of years. So on the myelin sheath, that myelin is the insulating coating around nerves, you get kind of these proteins that are kind of sprinkled throughout it, and a few of them are named there. I'll kind of draw your attention to MOG. We'll talk about that a little bit later. You take that myelin and you take those antigens, you flag it to the immune system, you put it in a mouse, and sure enough, in a few days to weeks, the mouse has inflammatory episodes that looks like ADEM or MS, and you get the symptoms of those conditions. So how does that relate to the present? What are we doing to kind of advance diagnosis and treatment of this condition? So let's define what MOG is. It stands for myelin oligodendrocyte glycoprotein. This is a protein that is, again, expressed on the myelin sheath and the myelin-producing cells called oligodendrocytes. It provides structural integrity to the myelin sheath, so it's a pretty important factor in it, and you wouldn't want that to be injured. And then researchers have noticed that children who have ADEM-like illnesses are often the ones who have the highest MOG antibodies and are the ones most commonly found to have MOG antibodies. So what does that mean? And here I'm kind of simplifying a number of studies, but I just want you to kind of get the general concept, which is if you take a group of individuals who have ADEM and you test them at the very beginning, at their onset of disease, about half of them actually will be MOG positive in a pediatric group. Half will be negative. If you later look at them and you follow the ones that don't go on to have relapses, often they will be MOG negative. And even if they were MOG positive before, there seems to be some sort of acknowledgement of the immune system that that was a bad thing to do, and then they no longer make those antibodies. But in the case of multiple sclerosis, in the case where ADEM is actually perhaps multiple sclerosis is actually misdiagnosed as ADEM, you also get MOG negativity. So it leaves us with this kind of third group, the people who have something that really looks like ADEM on imaging and in clinical presentation, but they have relapses after it. And we found that mostly the relapses can be optic neuritis or transverse myelitis or an NMO-like syndrome. A lot of them are MOG positive. So what do we do with this information? I think it's generating a lot more questions as much as it's giving us answers. And the things that we're asking right now is, are these antibodies pathogenic? We know that aquaporin 4 in NMO is very predictive of future relapses and will lead somebody to be on treatment. Is it the same way for MOG? And then are MOG antibodies associated with a good or bad outcome? We know people who have a monophasic disease are often negative. We know people who go on to have MS, which often is a kind of a worse disease than typical ADEM, have the MOG or don't have the MOG antibody. And is it really having the antibody, or is it how long you have it over what time that describes whether you will get a relapse or not? All right, I kind of want to shift gears a little bit and talk about how we measure outcomes in ADEM. So for transverse myelitis, you might do something like test somebody's muscle strength or check their walking speed. For somebody who's had optic neuritis, you might have them look at a vision chart and read it out loud. But it's a little harder when it comes to measuring how the brain is working, and we really rely on our neuropsychological colleagues to help us with this part. The brain is a very complex and multifaceted organ, and helps you on a daily basis navigate pretty difficult decisions. So what that testing might look like might be more like this, where you're doing things that really stress your cognitive function, mental rotation, putting pegs in a pegboard, remembering that complex figure. So what have people learned from studying the neuropsychological outcomes of ADEM? The data is a bit mixed, but I'll summarize, and I think some themes emerge from this, these sets of data. First, a group looked in 2003, and they found In general, ADEM patients had very similar scores on average with a normal healthy control. But if they look closer, specifically certain cognitive processes like short-term memory, processing speed, executive function, things that really a child or adult needs to navigate daily life, they were actually impaired in those areas. The next group asked the question, does the age in which you get ADEM matter? And they split the cohort into a younger group, under 6, and an older group, over 6. And they found, on average, the younger patients seemed to do less well in terms of intellectual and academic functioning. So that, seems to make sense. This is a really critical time in language development and figuring out, social structures. But unfortunately, the next group who looked at this topic, they kind of found the opposite finding, that really there was no association with age of onset and cognitive impairment, and if anything, the older kids seemed to suffer more. I think all of these studies are limited somewhat by having small sample size. I think on average they only had about 15 patients, and there was a lot of heterogeneity and when they did the testing. So I think the things that we can kind of glean from this data, though, is that if we look hard enough and we ask the right questions, there are cognitive deficits, even people who've had mild cases of ADEM. I think that's to wake up everybody who's fallen asleep during my talk. So how else do we measure outcomes in ADEM? So, it's pretty simple, but maybe we don't do this enough, which is to ask you as the patient or you as the parent. In some structured way that we can measure that. So doing patient-centered research has been certainly a move that we've been making in the medical community. This kind of brings me to I'm helping with this, a study that we're doing at UT Southwestern called Aperture. This is looking at both adult and pediatric ADEM, and we're using a number of different tools to measure outcomes, including clinicians' assessment, neuropsychological testing, and then parent and patient surveys. And our goal in this is to see, are there any patterns that emerge? Are there certain things that the people who do well or do poorly, do they share anything? And is there any way we can intervene to make the outcome better for everybody? So I think we have one foot in the future. And this is a model that I think we may be using quite soon in terms of follow-up with ADEM. Many of you have heard about the MOG testing, and it will soon be commercially available. So at the very outset, you might test MOG just to see if a child makes these antibodies. Around the same time we get a repeat MRI, you might test it again. And if it stays high, that might mean that the child or adult has a higher risk of continuing to have relapses. And that will tell us that we need to continue surveillance pretty closely. And then I think a big part of it is also assessing how people do fully, not just kind of looking at them and saying, well, they look fine, they seem to have gone back to normal. We really need the data to see that, yes, this child is doing well. And if there's ways we can intervene on their strengths or weaknesses, I think we can find out that through neuropsychological assessment and provide the necessary support. So future directions, I think the future is bright for this field. I think we're just at the very beginning of understanding different kinds of ADEM, that it's really not one disease, but multiple diseases that have the same phenotype or outward appearance. We're developing better diagnostic tests. We're using MRI better, and we're testing for certain antibodies that may have some role in predicting relapse risk. And we're hopefully making follow-up better, that we actually get objective data about how children and adults do after ADEM. And all of this is in our grand goal, which is to improve quality of life and patient outcomes for everybody who gets these conditions. So with that, I'd like to thank the TMA. I'd like to thank all the patients and families. Here's a picture from our TMA summer camp in Kentucky. It is great fun, and encourage everybody who has a child to come. And then these are some of the goofballs I get to work with every day, and definitely makes things fun. All right, that's all I have. Thank you.